Hi everyone, welcome to today's webinar. I am Maggie Dunn with Becker's Hospital Review. Today we will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session and the remainder of the webinar. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it's now my pleasure to start today's webinar by introducing you to Scott Becker.
Great, and thank you for joining us today. We've got a great talk from NewYork Presbyterian and UC Irvine on what to prioritize in healthcare M&A from a CIO health IT perspective. We've also got Andy Nieto from Lenovo with us to give insights as well. Over the last couple of years, there's been sort of an explosive growth in M&A globally and particularly in healthcare. We've got a great deal of healthcare system level mergers, whether some of the biggest Catholic health systems in the country or at the payer PBM level, and even there's discussion now of Walmart Humana looking at merging. Just a tremendous amount of affiliations and mergers going on in healthcare and continuing. In that context, there are just a flurry and array of health IT challenges in terms of integrating systems, deciding what's going to be the lead system, how are you going to work with hardware, how are you going to work with software, and so forth. Both New York Press and UC Irvine have been involved in a good deal of affiliation activity. We've got great CIOs on the phone to talk about some of their experience, and Lenovo brings tremendous expertise, Lenovo Health, to this as well. With that brief introduction, I'm going to ask Daniel, Chuck, and Andy to briefly introduce themselves. Daniel, why don't I start with you?
Great. Thanks so much, Scott. I appreciate it. I'm Daniel Barchi. I'm the Chief Information Officer at NewYork Presbyterian. We're an $8 billion health system located primarily in the New York City metro region. We've got two hospitals that serve as the university hospitals for Weill Cornell Medicine and Medical School and the Columbia University College of Physicians and Surgeons. And we date back to about 1778, so we've been around for a while. Most of our history has been two major academic medical centers in Manhattan. We actually have about 5 locations in the city, but we've recently acquired 4 hospitals in the suburbs and boroughs of Manhattan. So we have a New York Presbyterian Queens location, a Brooklyn location, and 2 northern Westchester locations. And so in the past couple of years, we've grown from being only a large academic medical center to being one with regional hospitals through M&A. And then we've grown a physician practice as well. So many of the experiences we'll talk about today are reflected in what we did to bring in those health systems and hospitals to our larger organizations.
Thank you, Daniel. And Chuck Podesta, an introduction on yourself and just a little bit of background on your experience with M&A as well.
Sure. This is Chuck Podesta. I'm the CIO of UC Irvine Health. UC Irvine Health is actually part of a 5 hospital system, loosely federated. The University of California systems is UCLA, UC Davis, UC San Francisco, and UC San Diego. And we just completed a big Epic implementation using UC San Diego's instance. And as part of that, we're actually finishing up on merging our IT departments together from a support perspective. Prior to that, from a M&A activity, I was at Caritas Christi, which is now Steward Health, when Ascension was involved in an M&A with them. It failed, but learned a lot through that process. And then at Fletcher Allen, which is now University of Vermont Medical Center, we did a big Epic implementation there and then acquired a community hospital in Vermont and then 2 hospitals in New York with different EHRs, different systems, and created 2 ACOs in the process. So hopefully with that background, been a CIO for 25 years and hope to provide some insights, based on that experience.
Thank you very much. We're fortunate to have both of you on the phone today with your different experiences in merging large systems and touching different M&A activities. Andy, yourself as well. An introduction from yourself and some of your thoughts or background in M&A too.
Thanks very much, Scott. So my name is Andy Nieto. I'm a worldwide healthcare solutions manager for Lenovo Health. And here at Lenovo Health, my role is specifically to introduce technologies and understand the market demands to drive innovation within the Lenovo environment. Prior to coming here, I was part of Allscripts Community Record and worked with a number of M&A customers as they leveraged Allscripts Community Record to transition data between multiple EHR solutions. Prior to that, I was the operations director for a pharmacy benefits company as we merged 11 different pharmacy and compounding centers across 28 states, and I ran the technology integration operations across all those integrations.
Wow, so you've had a great deal of experience with this as well, and I know it's a big, challenging issue. Let me start with Daniel and Chuck. And Daniel, as a healthcare organization begins the M&A process, how are decisions made about core IT issues addressed as a part of the M&A strategy? How early do those issues surface, and how do you look at those issues?
Sure. So I think the textbook answer is you begin to think of them from the very beginning. I think the reality, and I'm interested to hear what Chuck and Andy say as well, is generally there's an overarching business strategy that drives hospitals or health systems to merge or be acquired. And those are sometimes secretive conversations and then very business and operations focused for quite a while before people think to bring in technology and start to solve those larger issues. There are general broad assumptions about the fact that we can just plug and play, or we'll just use whatever's there for the near future and then figure it out later. I think practice shows that the earlier you get IT involved in the process, the better it goes. What I've seen in 3 different health systems that have done hospital acquisition is the costs of integrating IT are generally pretty far underestimated. It is never easy, even if you run just a legacy system, to keep it alive and assume that there are little to no costs in getting the data or even the revenue cycle data out monthly. And then when people realize, it's really not going to work that we leave, the newly acquired hospital on its legacy system while the rest of the health system runs on an integrated EMR or an integrated ERP or revenue cycle system, and we really do need to bring them in. And then there's a plan generally to get it done later. But to sum up, I'd say the earlier IT gets involved, the better these things go.
And thank you. Chuck, some of your thoughts on the same issue. As you begin the M&A process, how are decisions addressed?
Yeah, I agree with Daniel on the IT being brought in early. What I try to tell people is we want to be the first call on any type of M&A activity, not the 5th call, because by then it's too late, and whatever plug number they put in, as Daniel said, it's probably not going to be accurate at all. What I try to look at is what I call M&A math, which is when 2 organizations are joining together, is it 1 plus 1, does it equal 3, from a savings, market share, benefits perspective. And then on the cost side, you're looking for 1 plus 1 equals, 0.5, something in that area. So it's a different type of math that you're looking at. Again, you have startup costs, but if you're looking at the long run, 5, 10 years, how does that math work in for the organizations? And it also depends on what kind of M&A you're looking at. Is it 2 equals coming together? As in the case of an Advocate and Aurora, or is it a large organization gobbling up a smaller one, which would have been my experience in the University of Vermont. In that type of M&A activity, your IT strategy will be a little bit different if it's 2 equals versus a big one taking a little one. As what we did in Vermont, for example, is we let them stick with the EHRs because we had a statewide HIE. So we knew we could move information around in the short term. That allowed us to let the business side merge, get the business strategy at the health network moving forward, knowing that eventually we'd want to all be on one EHR, but it allowed for a better planning process than what you see sometimes where you immediately go into replacing electronic health records.
Scott, I think one of the things that you heard from both of us was that people tend to underestimate the dollars. And this is not M&A, but it's very similar. In my experience, probably Chuck's, probably anybody who's done this from a technology point of view. When you build a new building or a new hospital, again, not M&A, but the same kind of thing we run into, it's always good as a technology leader to ask early in the project, hey, are all the end user devices covered in the cost of the project? Because the people putting together the cost of, say, a new building or a new hospital or a new corporate center, they want to minimize it, and it's the construction people who are generally putting together the first cost, and they don't want to bump it up with another $20 or $30 million worth of computers. And unless you go and ask that question, hey, are the end user devices somewhere in the budget? People will say, oh no, we thought you were just going to eat that out of your regular IT budget. So again, not M&A, but another important point to consider.
Right, but a big issue in terms of cost and timing and just planning. So thank you. Another question. In the first part goes to evaluating how you look at things post M&A, and the second will be a couple of pros and cons in that strategy and what things make things less or easier than expected. So the first question, and this is again for Daniel and Chuck and Andy at any time weigh in as well, and I know the next question will be for you. When evaluating the integration of IT systems for a new post M&A healthcare organization, did your organization typically do one of three things? Integrate existing systems, 2, keep them separate, or start from scratch by adopting a new net IT system? And Daniel, why don't you start with them? Because I know you guys have done a number of acquisitions in the last year. Do you just bring the new systems in from these hospitals, some of the community hospitals you've bought or acquired, or do you keep them separate? How do you handle the IT as you bring in some of these new systems?
Sure. I'll address it both from the people and the systems. My feeling is that the people are the important part of the equation, and that healthcare IT is really 80% people, 15% process, and only about 5% technology. And it is a false promise to say, oh, we're going to let that legacy IT team at that hospital continue to run independently because there's value or there's savings there. Really, the quicker that everybody gets integrated into one team, no matter where they happen to sit every day, it's important because it drives the larger savings and integration and, quite frankly, a better clinical outcome for physicians and patients. So generally, what we've done is quickly integrate the people. So on, say, November 1st is acquisition day. That's the date that the legacy team joins the overall team, same policies, procedures, one organization. It is always a fool's errand to try to assume that you're going to cut over that bit of technology on the very day that the M&A happens, because there are any number of things that can throw it off, and then you're left bare trying to move up or move back a date. So we've generally integrated the people first and then run the legacy systems in place for some period of time, as short as 2 weeks and as long as 2 years. The 2 years is if we're going to an integrated EMR for the larger health system, just put that acquired hospital somewhere on the planning timeline and pick them up as we roll past. And so to me, integrating the systems technology-wise is really important, but it doesn't have to happen immediately.
And then in terms of ultimately, does one system, the existing system from the main health system that's merging in the smaller health system, does that become sort of the dominant system? And I did hear you, and I think it's great advice that first you'll figure out the people issues and then sort of the systems issues. But you typically end up moving the community hospitals that have joined New York Press into the New York Press system?
That's correct. Mostly, and it's just a question of size and scale. If we're running a $7.8 billion health system on a certain timekeeping system or revenue cycle system, and then we add a $20 or $40 million revenue location onto it, we're just going to put them onto the same system. And it's mostly about scale and what's been working.
And sooner or later, on day one, you might keep them separate, so you're still running their separate systems, so you don't have too much upheaval as you merge the people and integrate the people. But sooner or later, you'll probably integrate all things or most things.
Absolutely. I'm a big fan of integrating. You know, Chuck mentioned HIEs before, and to me, that's a good plan. The way he described it was a good stepping stone to further integration. But the days of best in breed are long gone, and the efficiencies and, quite frankly, I think the patient safety associated with running everything on a single system outweighs the benefits that running a specialized system might have. So to me, it's just a question of time. There's no need to rush into it, but if you've got a 5 and 10 year planning horizon, you always make the decision that's going to be best for the physicians and the patients in the end.
That's fabulously helpful. Thank you. Chuck, your thoughts on a similar question. Integrate existing systems, keep systems separate, or start from scratch?
Yeah, no, I've done it both ways, and I have to agree with Daniel on the people side of it. In Vermont, we did leave them on their EHR, but we did merge in the IT department. So as the CIO there, I became the CIO of the network, and the community hospitals, the IT staff all reported to me, even though there were separate EHRs at the time. We managed those for a period of time until it was decided to move forward with the integration aspect. And so that went very well. On the UCI San Diego experience, it was the opposite. We actually did the implementation first, and then merged the IT departments. Some of it was done during the implementation to get ready to go live, but the majority it was done post-implementation. I got to agree with Daniel. I would have, if I had a do-over on that, I would have recommended moving forward with integrating the IT staff of both organizations, and then moving us on to San Diego's instance of Epic. In this case, I think that would have smoothed things out. It would have made governance a lot easier. You know, we did have a positive shared governance experience, but it was a lot of work. Unfortunately, in that type of scenario, typically you end up with one CIO, and we were two equals pretty much. So it would have been interesting to see how the decision would have been made on whether the UCI CIO was kept to the San Diego one. So luckily we didn't have to go through that.
Thank you. And just one further question on this. In Daniel and Chuck, the integration process generally, more or less difficult than anticipated, and why? Maybe speak to that from one or a couple of your experiences. I'm sure the more you've done it, you're better able to assess the difficulty. But Daniel, any thoughts on that? IT integration processes more or less difficult than anticipated, and why?
So
and Chuck, same question.
I'd say it's always easier than it's thought to be or feared to be. At the end of the day, you know, people are IT professionals who are well-trained and they work for an organization that wants to see them successful. The longer that you wait or don't pull the trigger on integrating, the more concern, rumor, innuendo about what might change or what goes wrong might happen. My most successful integrations of IT teams have happened when we've laid some good foundational outlines, we've set some operating principles, and we've committed to treating everybody fairly, and then we just do it quickly, and then figure out what's working well and what's not, instead of long negotiated planning. You know, I'll tell you the hardest M&A story that I've ever heard of. I was a naval officer in the 90s, and we were operating in the Baltic Sea. And at one point in 93, we spent a couple of weeks operating with the German Navy. And it was the German Navy at that time, and previously it had been the East German and the West German Navy. And darn if these people weren't, you know, both staffing the same ships. And so they had gone from being enemies to being, you know, shared officer wardrooms and sailors operating one or another's equipment. And they had to figure out customs and protocols and how to work with one another, but they simply, I was going to say pulled the trigger, but I guess that's not an appropriate metaphor. They simply joined together and figured it out. And so if organizations like that can do it, it shouldn't be that difficult for us as IT organizations to figure out how to integrate pretty quickly and look out for each other.
And Chuck, any thoughts on the same question? Just I mean, that's obviously unusual when you had former military enemies integrating their processes.
Right.
But Chuck, how about some of your experiences? Fascinating comment by Dan that actually sort of not as bad as sometimes expected. Thoughts from yourself on that?
I think speed, what Daniel touched on was, I think speed overcomes that anxiety. And I think that's really, really important. And I've done them both ways, fast and slow. And fast is better. But just to add to a little bit what Daniel said, in my mind, it comes down to culture. And that's what I've seen in a couple of different instances. In the case of Vermont, we actually were trying to combine our IT departments with Dartmouth because we were both on Epic and academic medical centers, and it kind of made sense to do that. But at the last second on that, the 11th hour, we decided not to do it. And it was basically, we could not merge those cultures together. They were so different on the way they did things between how Vermont worked and how Dartmouth worked that we just pulled back. On the UCI San Diego experience, a little bit different. We do have different cultures, but from a CEO, COO, CIO perspective, we all had very good relationships. We're able to work through those cultural differences to merge the groups together, even though it took a little bit longer than we would like. And it was, but because of those relationships that we built, we were able to work through those culture issues going forward. But in my mind, if you've got two very distinct cultures that work differently from a customer service perspective, how they treat their people, it can be very difficult to merge those two groups together.
But it's fascinating how in this technical area, how much you and Dan have both commented and how important the people issues are and the culture issues are. I guess that makes sense, but it's such a fascinating observation how that overrides so many other things in terms of all the technical issues and challenges and so forth. Andy, let me turn to you for a few moments here. In terms of IT device acquisition planning, lifecycle decisions for upgrade, refreshing of hardware, tablets, notebooks, desktops, workstations, all kinds of stuff. How is it impacted by M&A? Does that end up getting slowed down because people are so busy doing other things, or do people expedite it to get everybody in the same things? What's your experience been with that situation?
Well, based on my observation, the first thing I will say is people are absolutely the critical aspect. I agree with everything that Daniel and Chuck said. Anytime there's M&A activity, whether it's a merger of equals or an acquisition of a smaller organization, there's it is change, and how the leadership handles that cultural shift, how the leadership guides this concept of where we're going, is absolutely critical to the success of the project. We know that during M&A, typically before the merger, no one's spending any money because they want to look the best on the balance sheet, right? So there's lots of delay in the refresh of hardware. There's lots of delay in in moving forward with plans and things like that. And my advice in that environment has always been, you're going to add even more delay if you do it right. And to do it right, it is a matter of bringing in your hardware vendors and the vendors from both sides. It is rather rare, actually, that both sides are using the same vendors. And so to bring in those vendors and even competitive vendors and say, which one meets the vision, which one meets the standards, which one in a net new environment is going to be the best for the organization. I believe that it was Daniel that said you need to allocate the money just as if you were doing a new building for that infrastructure for those end user compute devices. If you've allocated that in the planning out front, then you can bring in the vendors, and I would include the EHR and all your other technology vendors, not just the hardware, and say from a vision perspective, from a destination perspective, which is the best partner, and then come together with a strategy for how you address both sides. But it starts with the people. It starts with saying who needs to be the leader, and with those leaders, what's the culture going to be, and what are the demands within the organization.
Thank you very, very much. And let me ask you another question, Andy. And I know you've seen this a lot, and it's common. Two organizations have standardized on very different IT platforms or providers. How do people address, you see this in big systems, one's on Cerner, one's on Epic, you see it in all kinds of ways. How do people address, I mean, I know the Aurora Advocate, which Chuck referred to, they had those kinds of issues. How do people, or maybe not Aurora, I think they did, but how do people address some of those issues?
Well, the first thing is that we know anytime there's M&A activity, there's an opportunity to reevaluate workflow, reevaluate efficiencies, and in doing all of that, you also have to really look at how do you reduce physician and clinician burnout, overburdening the current environment. And so the first thing I always recommend is get your participant advisory board together. Get a member of each of the organizations internally, whether it's nursing, clinicians, techs, etc., to create an advisory panel and begin to say, okay, we're going to standardize on this technology. Which workflows are getting re-engineered? Which environments are getting re-engineered? And help involve the participants. So if the leadership is saying this is good, rah, rah, we're all on board together, and the participants, the thought leaders within your existing organization, the new culture are saying we're behind this, we're a participant, then it's a matter of simply taking what the best in breed vendor you've chosen to go with and say we've standardized on this notebook, this laptop, this tablet, this is what we're going to go forward with. But it's by having influence from those key participants, those key decision makers, those key vocal advocates, you reduce burdens of I don't want to do that, or I'm a Dell guy, or I'm an HPA guy, I'm a Lenovo guy, I'm an Acer guy, whoever you are. It becomes more of, hey, we're moving forward with this, and culture overcomes so many technical agreements, but also holding your vendors' feet to the fire. If they say they can deliver X number of systems on Y day that are going to be imaged, you need to hold their feet to the fire. They better deliver, and if they make sure that they're a participant in the discussion. If your vendor is willing to take the time to participate in the EHR migrations, in the data migrations, in the hardware migrations, and really be feet on the street, present, and during all the process, you're going to have greater success than if you're having to call and open up trouble tickets for every new thing that shows up, because new things will simply show up. That's just a reality.
Thank you very much. Let me turn back, Andy, to Daniel and Chuck for a moment. Daniel and Chuck, a question about the clinician perspective during M&A. How much time and effort do you spend, and how do you account for clinicians' viewpoints at all levels from an IT perspective during an M&A process? How much of those discussions are there with getting your clinical staff comfortable with what changes may be down the road, or whatever the things that can come up in M&A? Daniel, did you want to start, and we'll go to Chuck?
Sorry. Sure, I'd be happy to. I think in most cases, there's a larger business decision that's made. And as Chuck and I were describing earlier, we tend to go with integrating acquisitions into the larger enterprise. So there's less about, hey, doc, what would you like to see? And more, hey, doc, you're using XYZ today, but it's going to be changing to ABC. And here's the time frame. I'd say that in the best M&A that I've been involved in, this is a core part of it, that we don't just pick a go live date and put a project plan together and do it. It's a thoughtful process where we're communicating and meeting and training. The more time we spend doing that, the better outcomes that I've seen happen. But it is that is more art than science, particularly when a system has been really tweaked and optimized to meet the needs of local clinicians, and you're forcing them to adopt a more neutral or standardized system, which isn't quite what they've been using before. So I think there's great value in doing it, but it's one of the harder soft skills in all of this.
And really what you said I thought was fascinating. Let me make sure I got this right. Was sort of the speed and energy of these big mergers and the business drivers of them, it's not as much consensus building with your clinicians as it might have been 10 years ago. It's much more ultimately deciding this is kind of where we're going and we need to work with you on it.
Yeah, you stated it correctly. The leaders of our health enterprises, the CEOs and COOs and chief medical officers, are at the point where even if lobbied by the chairman of XYZ department about why his or her system is really important and needs to stand alone, our leadership anymore recognizes, I recognize that you like your legacy system, but here's why we're using our integrated EMR, or here's why we're using one lab system across the enterprise. And so it's more a question of hearing people out and talking them through it than it is any kind of evaluation and decision process anymore. That said, it's still important to have those conversations and show how there can still be value, or you can pivot some of the IT team's resources to the side of that physician to help him or her using the new system or optimize their build out. So it's maybe almost as good as what they had before, but in some cases maybe better.
And Chuck, let me turn to you on a similar question. How in today's world, with the speed of merger, the discussion happening at some of the highest levels, do you then get into the weeds and work with your clinicians to deal with their thoughts and processes? Some of your thoughts on that.
Yeah, just to add what Daniel was talking about as well, which I totally agree with. You remember the old saying, it's the economy, stupid. In these type of M&As, it's the faculty, stupid. And you've got to get them working together. And what we did in the UCI San Diego experience, very early on, we created faculty summits. And we picked Saturdays halfway between our two organizations, fed them, had cardiologists sit with cardiologists, and various specialties sit with their counterparts in both organizations, walk through kind of what we were proposing to do, and then talked about real life problems that could be solved by us coming together and how our patients would benefit from that. So we brought it down to kind of their level and the value to them. So what's in it for them with this particular M&A and with this particular implementation of a single EHR, and let them talk about what the future is and what some of those problems could be, and how we could solve those. And we even allowed them to come up with some guiding principles around the project. And one that they came up with, which I really loved, was we would standardize on the build, but we would always change it based on the best practice of either organization. So if we had a best practice, San Diego would change the build, they would change their practice to our practice, and vice versa. And the faculty were the ones who drove that. So my feeling is the success that we're having now is based on those summits and the adoption, of the technology. They felt, a part of making that happen.
Thank you. Let me do this. Let me move to another question, and we've got a whole number of questions from the audience. We've got about 20 minutes left. So core advice, your best advice on organizations embarking on M&A from a health IT perspective. And we've got 3 in the room on the phone from New York Press, from UC Irvine, and from Lenovo Health that have had magnificent experience in that. So just if you could sort of drill down to your best few points of advice on how to handle IT in the context of M&A, would love that. And I've got this regular order going of Daniel, Chuck, and Andy, so rather than upsetting it, I'll stick with that. Daniel, do you want to start?
I'll go really quickly. I'll say early, fast, and listen.
Do you ever find, let me ask you a question on the fast. Does fast, but can't fast, and I've heard and understand totally, once you're in this kind of process, there's tremendous anxiety amongst different departments and different users. So the quicker you get past that process, the better off you are. Does fast, though, ever cause you problems, or do you just figure you're going to overcome those problems just because when you're integrating very different systems, does fast outweigh, how do you balance that with care and caution versus the anxiety of going slow and people not knowing what's going to go on?
Yeah, that's a really fair question. When you're bedside with a patient and you're working on their medications, you've got to be 100% right. When you're making decisions about integrating systems and large teams and organizations, and business decisions like that, when you've got 70% of the information, that's probably enough, and you get the benefits of just going with it and spending all of the time and energy fixing, tweaking, and optimizing post-integration. That has a lot of value, that has much more value than every hour that you spend pre-integration trying to imagine what the issues might be. So I think that as long as we're not talking about patient care where we've got to get it perfect every time, going quickly, getting yourselves in the new world, and then figuring out what that looks like is the best way to go.
Gotcha. So early, fast, and with a clear vision of what it's going to look like. And figure you're going to be tweaking things. You might get it done quickly, but you're going to be tweaking things for a while, for a long time as you evolve.
Exactly.
But that's okay. Better to make the decision and commit and get it done and commit, we're going to get this done, than have it dawdle. Fabulous. Chuck, your best thoughts on advice in the context of M&A from an IT perspective?
I would say first assess the culture, just because I've run into this in more than one occasion, and which can become a huge barrier. So assess that culture, and it doesn't slow you down or stop you. It's just more allows you to see what you're about to face from a cultural perspective, merging two groups together like that. So it's more of a seeing what the risks are up front, so you can move forward quickly, but also make directional changes based on some of those cultural issues. Also, moving fast, totally agree, but you could potentially be selective around that. And I'll give you a quick example with UCI in San Diego. We were beginning the planning part of the process, the faculty summits that I mentioned, and the CTO left at San Diego. So we immediately took our CTO, and we had not planned on merging the IT departments yet, but made him responsible for everything on the infrastructure side of both organizations. That was huge because it gets back to Andy's point. We were able to align the infrastructure, the desktops, the storage, the networks. We had time to really merge those groups together. We put San Diego on our ServiceNow platform for the help desk and merged that in. So the things we could do without merging the entire department quickly, we stepped through it selectively, and that worked really well to get us ready for the implementation. But then I agree with Daniel. From that point on, you've got to move as fast as you can. And the UCI experience after that, I wish we had moved quickly, but because of the cultures and some of the other things that were going on, it was that part was difficult to do.
Let me ask you a question about moving fast. Is there ever a time where that includes keeping some legacy systems, going at different institutions, or is moving fast include almost always picking the lead system in terms of IT and not using different types of legacy systems?
So I think that in many cases, legacy systems are going to be around for a while. I mentioned before having a 5 and 10 year horizon. That is not that long a time, especially when we're dealing with hundreds of clinical and operational and financial systems or a large integrated EMR. So I've always integrated the teams very quickly and then put together plans for each one of the different clinical and financial and operational systems. Some of those might happen in the next quarter or two, but some of them aren't slated for 2 or 3 years down the line when they come to end of life or a contract is up. So there's fast, but then there's thoughtful. And to me, it's more important to have a plan and be executing on it well than it is to just rip and replace quickly.
Well, that's a very helpful clarification. I was just trying to sort of work through your thoughts on this. So it's moving very fast, and both of you agree moving very fast on sort of integrating teams, with obviously some caution on the politics and the cultures and so forth, but the quicker you integrate teams, the better off you are, because you don't have people worrying about what's their job versus that person's job. Are they safe or they're not safe? So integrating teams very quickly and developing a plan very quickly, and then the plan might be done in a more processed time frame to make sure you're not, if you rip and replace a legacy system too quickly, you could have all kinds of problems, because you could have problems processing while you're doing that and integrating and so forth. So, Dan, have I summarized that correctly?
Yeah, I think you said it really well. I'd say policy, weeks, people, months, systems, years.
Great, thank you. Andy, you've had so much experience with this. Some of your thoughts on your best advice, and you've seen this not just from a hospital health system perspective, but a PBM perspective, a variety of other different types of healthcare entities and systems. Some of your thoughts.
So my first piece of advice is always pick a go-forward strategy. Once you know your vendors and your systems, your go-forward standardization. What does tomorrow look like in your standards? So knowing what your infrastructure standard is going to be, so that you don't have to worry about, okay, the next acquisition cycle, the next pieces, we know what vendor we're using, we can go forward. My second piece of advice is to engage all of the vendors, even the ones that you're end-of-lifing, you're moving beyond. So if you're moving, for example, one hospital's Allscripts and one's Epic, you engage Allscripts if they're the one going away and you're moving to Epic. Engage Allscripts and say, help us do the migration. At the end of the day, we're all professionals and we're all committed to patient care and quality, and good professionals should be a participant in the next steps. Even if it's the end of the relationship, it should be a good exit, and you should expect the vendors to deliver on a good exit. So standardization and a good exit. And I'll echo what they've said. Ripping off a Band-Aid slowly just hurts longer. So fast is very, very important. Especially in an acquisition environment where there may be frustration and hostility. The longer you keep that separate and not integrated, the more painful it actually is.
And that's really helpful. And in terms of defining, I think Daniel and Chuck and you have hit this very nicely on the quick and pace. What I heard was this comment of policies immediately, people issues pretty quickly, and then systems as part of a plan. And obviously you don't want to be running legacy systems for 15 years or for 10 years for longer than you have to, because there's just so much cost and people trained and inefficiency in running too many legacy systems. But I've heard you guys correctly. Policies and clarity right away, a plan right away, and people right away, and then the actual implementation of the plan will be done in a measured, intelligent way.
Absolutely.
Great, thank you. Chuck, let me start with you on a couple of the audience questions we have, and then go to Andy and Dan. Who takes the lead in IT decision-making during and after a merger? Who's the lead person? Is it the CIO? Is it the CIO in context with some other people? How do you look at that issue of who's ultimately making decisions?
We have strong IT governance in place. And what we did early on, we looked at a shared governance model with, and this is the UCI San Diego experience, and that worked very well because, we actually did not, the CIOs did not share this group, and I did not share the UCI group. We actually had our CMO and COO co-chair the IT group because we wanted to make this about clinical transformation and not an IT project. And it really show the organization that and have people at the leadership level take ownership of what we're about to embark on. And that worked very well. Certainly the CIOs are involved, doing all the work behind the scenes, the planning aspects of it, the policy aspects of it that Daniel talked about. We may be the initiators of that, but you just can't force your will as a CIO on an organization. You've got to have a real strong governance in place that's led by the business side, not by the IT side. We're an enabler to the business strategy. Sometimes we get out in front of it, and we need to, but for the most part, you want to be enabling it.
So I think that's a great point. So the CIO or your governance team or governance plan may be the core in making decisions, but at the end of the day, you can't make decisions that are out in front of the business people and their business plans. And they got to be in line with budgets and thoughts on what you're going to spend on things too.
That's correct, because ultimately, you're competing against other capital, and they need to see the whole picture so they can decide on where the organizational resources need to go.
Great. The same question, Daniel or Andy. How about yourself? Who do you see typically take the lead in your experiences on IT decision making? I know Chuck hit this really well, but some of your thoughts on where you see this or any differences in how you see this approached.
So this is Andy. I'll go. I regularly have seen the CIO and CTO kind of setting out the vision, but as I've said, if you can get a participant advisory council, something where you actually have the users who are well respected in the organization vocally say and support, this is the destination, this is where we're going, and even use them as marketing to the internal organization to say, Dr. Bob is on board, aren't you? To kind of drive that. Culture and the culture and people are the most difficult part, especially in an acquisition and not a merger. So getting the people and getting the respected members of the organization to go forward strategy have been the most successful in my experience.
Thank you. And Daniel, I want to have you touch on this question and just in what you've seen and who takes the lead in IT decision making. And I think a great comment by Chuck and Andy on culture and then also how, yes, we take the lead, but it's all subject to the board and CEO perspective and where they want to spend money. So, for example, if we wanted to do rip and replace on everything, the board still might absolutely say, well, we're not doing that right now.
Right.
So who takes the lead in IT decision making? And then also, how do you make sure newly merged organizations can share patient data? I'm going to transition you from the first question, who takes the lead, to the second question. I'd love your thoughts on both.
So I think Chuck and Andy said it well. By taking a leadership role, the IT leads can get it done and make sure that they're meeting the needs of their end users, who are ultimately the leaders of the organization and the physicians and the nurses themselves, subject to the board. I'd summarize it by saying, though, there's often a leadership vacuum, and the IT leaders, the CIO, the CTO, need to step up and articulate a clear plan that people can react to. But it's that vision that's really going to get the ball rolling. When it comes to the data sharing on the patients, it's interesting. Most of the organizations I've worked for are interested in getting the metrics and the revenue cycle numbers aligned quickly. It's easy to give access to all of the physicians of Hospital A access to Hospital B's EMR. It's as simple as just creating another login. And it might be more painful for the physicians because they have another password to remember, but at the end of the day, it's simply a different system. And a little sneaker net and swivel chair can solve problems really quickly and then allow the organization to think longer term about what the right plan is. Do we really want to invest a lot of time and money in building interfaces or creating a top layer to lay over both EMRs, or move Hospital B to Hospital A's EMR? Those are longer term decisions, but there are some quick and easy ways to get it done more quickly. But I think most people's experiences are that the metrics, the analytics, and the revenue cycle are the things that health systems want to align quickly.
Great. Daniel, I've got a couple other questions that have come in, and I'd love all of your thoughts on these. Let me turn to you quickly first, because one of them ties into something you just said. When putting together, you had said something about how someone, a CIO, a leader, he has to put forth a plan, an enterprise service vision or a vision what IT is going to look like, to be reacted to. And sometimes that's, no fun because you're going to get criticized on it, but someone's got to take the lead in doing so. How are the CIOs engaged? And Chuck, the same question for you and Andy. How early are you engaged in trying to put together that vision of what IT is going to look like and have people react to it? Are you involved in the letter of intent stage early on, or does not really get going in this till a little bit later in the process of an M&A activity?
So I'll go first. What I found that's interesting is my comments earlier were about generic hospital acquisitions, that generally there's a business reason for doing so, and then IT gets brought in later on as kind of an afterthought. More and more, though, what I'm seeing is, especially as we work with potential acquisitions of physician practices or other hospital partnerships, we're starting to think of the IT that we do, the artificial intelligence, the telemedicine, the robotic process automation, as one of the values we bring to the table. And so while IT used to be an afterthought, more and more recently, my team and I have been part of the original conversations, because part of what makes us look like an attractive acquirer to the potentially acquired institution is, hey, look what we've done already, and look at all of these things that we're going to bring to the table. And so that's been a good calling card in getting involved in the process earlier on, and one of the benefits of having invested in the advanced technology that we use.
Thank you. And Chuck, rather than commenting on the same question, let me ask you a separate question that's come in from our audience. You've got a legacy system and a system that's going to be the main system going forward. You're going to transition to put them together. When you sort of transition the legacy system to no longer be the legacy system, to sort of go away, is there a period of time that you run them parallel to try and make sure you don't have losses or problems? How long do you sort of run things on a dual track, and how does that look?
Sure. Yeah, I can talk specifically about that because we actually had to do that. At UCI, we were all scripts and a bunch of other best-of-breed systems before we moved to San Diego's instance of Epic. So early on, what I did was we actually did an RFP and brought in an outside company to take over our legacy applications, because I needed to get my people over to Epic as quickly as possible. And as you know, if you implement Epic, get people certified and productive takes many, many months to do that. And plus, I wanted them to see what the future was going to hold and not be stuck in the past with the legacy systems. And so we actually were able to save money because it wasn't a company that had an India base to it as well. So some of the support came from India on their Allscripts stuff, which actually lessened the cost of that legacy support going forward while I moved my people to a capital project. And then what we did was we just managed the legacy system. As we got closer and closer to go live, the enhancement requests that come in, you're basically in a break fix mode with that system while it's still in productive use, and you're not really doing any enhancements. We actually picked a date that we froze all the legacy systems. So after that particular date, which was months before we went live, we stopped making changes basically to that system. And we ramped down, because we used an outside company, we were able to ramp up and ramp down as needed on the support side. So, we might start with 30 people at the beginning of the project, and then by the time we were going live with Epic, I think we had 4 people left on the legacy side. And then you get into the archiving and decommissioning aspects of it, but that worked extremely well for us.
Andy, we're going to wrap up in a couple of moments. I wanted to see if you had some final thoughts on sort of either transition issues or what point you see the CIO jump in and really provide a vision as to what's going to happen with hardware, with tablets, with everything that goes into the IT, plan in M&A. At what point do you typically see the CIO and how detailed a plan do they lay out, sort of a vision for what's going to happen?
As early as possible. As early as you can get the leadership involved from the IT leadership perspective, and as quickly as you can get a decision on the standardization and the go forward. Where are we going to be tomorrow? Where are we going to be next week, next month? You can begin planning and moving towards it. Once the decision is made that X is going to be the go-forward system and Y is the go-forward hardware provider and Z is the go-forward infrastructure provider, then as quickly as you can get to that point, then you can begin saying, okay, here's where we are today. Now we can roadmap how we get there. If you have to be thoughtful. You have to understand, especially if you have a legacy system that has a unique offering, you have to be able to address that and as those come. But in general, as quickly as you can get the leader on board, focused on the next step, we especially see that in acquisition of smaller organizations where the decision makers are strongly invested in a smaller or legacy organization, a senior leader or senior leadership stepping in and saying, this is the go forward strategy. And you might have to have private conversations, but you really do need that leadership up front to say, this is what tomorrow looks like.
I want to thank you for those comments. I want to wrap up. I want to do just a couple of quick thank yous. First, our audience for joining us today. We greatly appreciate it. And then to our three presenters. I'll start, Andy, with yourself. The thing about Lenovo Health that I love is just incredibly intelligent and practical. Just a pleasure of a combination of skill sets, this intelligence and the practical implementation and working with people. So thank you very much for your thoughts today and what you guys do. And then it's always a great pleasure for me to get to visit with people like Daniel Barchi from New York Press, Chuck Podesta from UC Irvine, some of the top names in health IT today, some of the great CIOs, and just the willingness to share your thoughts, so openly with everybody is just greatly appreciated. So in addition, Maggie, the organizer of the webinar, thank you very much, Maggie Dunn from Becker's Healthcare. But Daniel, Chuck, Andy, I can't thank you enough. And obviously none of this matters without the audience joining in. So I thank you all for listening in today. Thank you, folks, very, very much. We'll follow up with you all shortly. Thank you, folks.
Thank you.
Thanks all.
Thank you.